when I hit start? Thoracic trauma, ITLS. What's this a picture of?
Thoracic trauma.
What kind? Smarty.
Training thoracic.
Yeah, we're treating a sucking chest wound here. Yeah. Okay, we're going to be looking at particularly the signs and symptoms of different types of major chest trauma. How are you going to manage them? The pathophysiology. The pathophysiology is very important. When you go to National Registry, pathophysiology is going to represent 20% of your questions. So as it moves across trauma, medical, everything, 20% of them are pathophysiology. And one of the things that we found is students have a hard time backtracking their brains. This is what we're presented with. How are you going to be able to recognize it based on your signs and symptoms? So backtracking to understand how we got to that point is very important, and particularly in chest trauma. We're going to look at an open pneumothorax, which means what? Yeah, gunshot wound, something where it's open to the outside. Tension pneumothorax, what's that?
Well, the air can't escape.
So we're talking about a buildup of pressure in the chest because the air can't get out. It builds up in the chest, doesn't have an exit point. Massive hemothorax, what's that?
Blood's pooling and there's some more
Yeah,
pressure.
a lot of blood in the chest. So this patient will most likely have a problem with what? Of course they can't breathe, but the big S word? Shock, yeah, they're going to be shocky. Flail chest?
I feel shock. We did a whole shock track.
Yeah. Flail chest, what's that? What's the definition? Two or more ribs broken in two more places consecutively. Yeah. So you may have a really large break, cover a large area, or very small. Cardiac tamponade, what's that? Bleeding in the pericardial sac, which is not very elastic, so it can't expand. So what's going to be the result of that?
Your Frank Sterling law.
Note your pulse pressure.
Yeah, you get decreasing pulse pressure and the blood pressure.
That outputs back.
Yeah, so blood pressure. Other thoracic injuries. So we got a lot of things to look at. Thoracic injury is a major cause of death in trauma. 25% of people that have major trauma, their cause of death is going to be directly attributed to chest trauma. Potentially fatal thoracic injuries. There are a few things that we can have a major impact upon if we recognize it and move. And those are two biggies. Oftentimes we're so busy with so many other things and our patient is deteriorating right in front of us. So that's why I said somebody's job is going to be to manage that patient's airway. If you got 10 people on scene or you got 3 people on scene, somebody's job is 100% to manage that airway. Because there are things that we may be able to do. Some things, not so much. Chest anatomy. You guys hopefully know all of this kind of stuff. You see where the diaphragm is? It's very high up here. When you look at it like this, is this a patient that is got a full chest of air, or they've just exhaled?
Exhale.
Yeah, because it's kind of curved and up real high. When he takes a deep breath, it's going to drop down and become straight, right? It's important that you recognize what the anatomy is here, where the clavicles are. See how straight those are? And the first rib actually is kind of right behind that. But you're going to be counting down well, this drawing is not perfect. You're going to be counting down these ribs when we're going to do our needle decompression. So in the labs, we're going to be feeling everybody's ribs because you've got to be able to identify the 2 areas where you will do a needle decompression. I put this line in right here because I want you to recognize that we have a nervous and vascular branches that run underneath your ribs. So when we do a needle decompression, where are we going to put that needle? We're going to put it on the top. So you've got to be able to palpate the top and the bottom and stay away from the bottom and hit the top. And of course ribs are much closer than it looks here, of course. And you can feel that on yourself. So you got to make sure that when you go above it, you don't go way above it, because where are you going to be? Yeah. Yeah, the bottom of the next one. So you got to be very careful about that. Then you can see, you know, this is lung space back here behind that. But just remember that there's a bunch of stuff down there that you don't want to hit. Okay, mechanism of injury. You can have blunt trauma or you can have penetrating trauma, right? With the blunt trauma, what type of injuries can you have?
Cardiac contusion or pneumothorax.
Probably due to what? If I hit you in the ribs with a baseball bat, yeah, you may get some fractures in there, and those fractures then may do other damage too. You know, Steve mentioned in children, they get hit by a baseball bat, they don't fracture, but what happens? They're going to get squeezing, compression injuries in there. With adults, more times than not, we're going to get broken ribs and fractures. You can also, because of that pressure, get blowout of hollow organs, because that hit's going to break some ribs, but it's also going to spread force through there. Deceleration forces, how does that happen? Yeah, you run your truck into a tree. You stop very, very quickly. You know, you've got those 3 or more impacts. First the truck hits, and then you hit, and then what hits? Your organs. Can you think of any organ in particular that slings around in there?
Heart.
Yeah, your heart, your aorta, it kind of hangs, it kind of holds the heart. The heart is not like sewed down on all parts. It kind of hangs there off the aorta. So we do get some aortic injuries because of those deceleration type events. Penetrating, what type of penetrating injuries do we have? Most commonly, you're going to look at stab wounds and gunshot wounds, but you could be stuck by a lot of other things too. You'll be looking for the energy that's transmitted through mass and velocity. And we look at this because it's going to tell us what? Mechanism of injury, pretty much. Based on, you know, if you're going 50 miles an hour versus going 20 miles an hour, you're looking at a greater chance of injury. So you do have to assess your scene and recognize and assess for a mechanism of injury. Tissue hypoxia, this is probably one of the biggest problems. If you have a compromised airway, and not just airway, but a compromised respiratory system, then you're going to get tissue hypoxia. And when we get to the head injury part, we'll look at this even more in depth because of the dynamics there. So you could have something that's interfering with airflow, but you can also have a patient that's shocky. They could have blood in the chest where they've lost a lot of blood that can make them shocky. Pleural pressure changes, pump failure, so you can get a lot of things that are going on that can lead to not getting enough oxygen to the tissues. Thoracic trauma, signs and symptoms. Man, this looks and sounds like everything else, huh? Shortness of breath, that could be almost anything, couldn't it? But if you got a patient that's got shortness of breath, you know that it's probably not an obstruction in the airway so much as some other dynamics. Chest pain, what is that third word there? Hemoptysis is what? Yep, coughing up blood. Cyanosis, distended neck veins. When you see a patient, a medical patient with distended neck veins, what are you thinking of?
Could be a tamponade or a pneumothorax.
A medical patient, not really.
Oh, sorry.
That's okay. You think it's backing up, so what do you say? Yeah, congestive heart failure, right-sided heart failure, that would probably come up first in your mind as a differential diagnosis. But in a trauma patient, you see that, what are you thinking? Something in the chest is preventing blood flow into the heart, right? Pneumothorax, attention pneumothorax, blood in the chest, anything like that could lead to distended neck veins. Tracheal deviation, we don't see that very frequently. That's a late sign. When the trachea deviates, which direction is it going? So if I have a tension on the right side, where is it going to go? It's going to move to the left. But as I said, we rarely see that in the field unless it's an old, happened sometime before we find the patient. Asymmetrical motion. When do we see asymmetrical movement? With what? Certainly with a flail segment. Pneumothorax, if you've got pneumothorax on one side, it's not going to move so much. Chest wall contusion, open wounds, that would be a dead giveaway. Subcutaneous emphysema, where are we going to most likely find that? You can point to it. Yes, usually right up here. And what causes that? Yeah, air escaping from a compromise in the airway. You know, usually the trachea has been compromised or part of the lung's been compromised. So subcutaneous emphysema, what does it look like? Yeah, like little popcorn under there, like little bubble wrap, really small bubble wrap. Really looks like somebody's been stung by 50 wasps right in that little space. It's kind of lumpy like. You don't want to press on it. I know that desire is great to do that. Don't do it. Tenderness, instability, crepitation. What's crepitation? Broken bone ends rubbing together. And abnormal breath sounds. Any chest injuries, you're always going to auscultate, and you're going to do it early and often. Okay, the deadly dozen, part of your primary survey. These are things that can kill your patient fairly quickly. And these also are often things that we can do something about. Airway obstruction, figure out what's causing the obstruction. Flail chest, flail segment, how do we manage that? Go to stabilize it, probably with a bulky dressing. No sandbags. No sandbags.
If they're having difficulty breathing, we want to assist their breathing too on that one.
To assess their breathing for
Assist. If they're having
Oh, yeah.
difficulty breathing.
Yeah, if you've got a flail segment in particular, you're probably going to have to bag them because they lose the ability, they lose that negative pressure in there, and they're not going to breathe well for themselves. So you won't be doing that. I was going somewhere with that. No, killing me. Open pneumothorax, massive. We've already talked about all of these. Tension pneumothorax, cardiac tamponade. These are the things you're going to be looking for with a serious chest injury. Doing your differential diagnosis. Did I skip something?
No, we just thought it was the deadly half dozen first.
Because I know what your attention level is. If I put all 12 on one page, you'll be snoring by the end. Myocardial contusion, traumatic aortic rupture. We're going to go through all of these specifically here in just a second. Okay, airway obstruction, secondary hypoxia. What am I talking about here? Hypoxia occurs secondary to airway obstruction. That's the way that's usually termed. And it can be just about anything, airway obstruction wise. But they may have bone, muscle, tissue, teeth in the airway that can block that. Anytime you've got a chest injury, you've got to assume a spinal injury. So anything that can do that kind of damage to the chest, they're going to have associated injuries. This picture right here is of a major flail segment, and you can see how this could be a problem if you've got this many broken areas on there. And this just kind of explains, and I hope all of you understand what happens when you have a flail segment like that and you lose that negative pressure. Normally, when the diaphragm drops down and the muscles between the intercostal muscles tighten up, everything's going to expand, and that creates negative pressure in there. So if you just open your mouth, air is going to rush in. How different is that from when you're bagging a patient? We call it positive pressure ventilation for a reason. The patient's not having to work on that. It's going to happen, you're providing that, and that's quite different. So in this case, this patient cannot get negative pressure in their chest, so they're going to have extreme difficulty breathing on their own. You're going to have to bag a patient with a significant flail segment like this. They can't breathe. They will get hypoxic and blue. If you see them getting blue around the gills, you've got a patient that's hypoxic, and that's long before you put on your pulse ox. You'll just see that. Is that a sandbag? I think that looks like a sandbag. Assisted ventilation. You may go ahead and intubate these patients. They may, if they go for long like this, they're going to be unconscious. Stabilize that, and then monitor them for other injuries. If they've got a serious flail segment like that, you're talking about a major energy transfer, so they're going to have other injuries besides just that. Open pneumothorax, a sucking chest wound, you guys know this. Why is the size of the opening important? Who cares if it's big or if it's little?
It goes to the top of each position.
Absolutely. If it's very small, air's not going to come through there because the trachea is larger. So any hole in the chest that is 2/3 the size or the diameter of the trachea or larger is going to be a big problem for you. The small ones, you're going to worry about infection and bleeding. You'll just cover it. But if it's just like a pencil size, that's not going to be a problem as far as pneumothorax. But a pneumothorax is going to interfere with their breathing. You'll notice that they will feel a lot of pain from that, even outside the trauma. If you have a spontaneous pneumothorax, that's a very painful thing for your patient. But you'll notice signs of hypoxia. What's going to be probably one of the most common early signs of hypoxia that you're going to see? Altered mental status. Yeah, if these people are still awake, altered mental status is a biggie. Their signs and symptoms are going to be directly related to how big that insult is. You know, this guy with this big one here, he's going to have a lot of your signs and symptoms. If it's just the isolated, 2 and 2, it won't be nearly as bad. He's going to tolerate that much better. Your treatment, this is, what do we call this thing right here? That's an Asherman seal. And we will look at that for this as well as we'll use those when we decompress, do a needle decompression. But always make sure that this is good enough to not be sucked into that hole. If you've got a big hole and you put some little piece of plastic over there, the next thing you know, you just kind of see it, being sucked into the hole, you've got a problem. So you got to make sure that you tape it down and leave a space so that you can burp it as needed. How would you recognize that you needed to burp that thing? Their respiratory distress increases. They'll probably become tachycardic. Yeah, your bag valve mask, they've become non-compliant. As you're pressing that, it's getting harder. So you know you've got to build up of pressure in the chest, and you're going to need to burp it. So that's why I say you have to be alert and be constantly reassessing your patient so you can recognize there's a problem. Okay, if they've got a lot of blood in their chest, it's really not so different than having a lot of air in your chest. It's going to cause the same types of issues. You probably can't see through the lines. Yeah, you can see. So if they've got a lot of blood in their chest, they're going to be hypovolemic probably. You can hold up to 3,000 cc's of blood in your chest. That's a lot of blood, right? So if you've got a lot of blood in your chest, you're going to see probably flat neck veins because all the blood is somewhere else. It's not flowing through. Or if it's not so much that they've lost that much blood in their chest, say it's a bunch of air in there, but it's putting pressure here on the mediastinum that it prevents the heart from expanding, contracting, and it puts pressure on the lungs also. That can be a problem. But you're going to auscultate the breath sounds. See if you got it on both sides. If you percuss, if you tap on there, it usually feels kind of dull if the chest is full of stuff. And your patient would be shocked if they've got a lot of blood in there. That's going to be a load and go. There's not a whole lot we can do about that. But this is a case where you want to provide or titrate fluid so that they keep a minimum blood pressure, 80 to 90. I've typed this in here. Does this generate any thoughts for you? Yeah, exactly. To find out what their pulse is, if you can feel a peripheral pulse, then you know they've got a blood pressure of at least 80. So if I can palpate this, I've got a blood pressure of at least 80, and I'm good with that. So when you're titrating fluids, if I can feel a pulse, that means they've got a blood pressure between 80 and 90, and I'm okay with that. You want to be very careful about giving them a whole bunch of fluid. I mean, even though the formula says 20 cc's per kilo, that is a lot of fluid. You got a patient, say, that takes aspirin, they're on Coumadin, they've just taken a big whopping hit to the chest, they're bleeding in the chest, they're shocky, and you're going to give them 3 bags of fluid. What's going to happen to that patient? Yeah, they're bleeding water. Exactly right. They're not clotting. So that's why in this case, it's important that you titrate that. All right? Very important. Now, when we look at head injury, we're looking at something completely different. So this is going to be a dichotomy for you. Look at tension hemopneumothorax. Yeah. If we've got a tension hemopneumothorax, what are we going to do? Yeah. Okay, with a tension pneumothorax, you'll recognize this because your patient's going to have difficulty breathing, dyspnea. They're going to be anxious because,
They can't breathe.
well, yeah, they are hypoxic. They're not getting enough oxygen to the brain. That's always going to freak you out. So they're going to have an increase in their respiratory rate. Distended neck veins because they got crack in their chest, right? Air can't get in. Blood can't get in. Breath sounds are going to be diminished, and they may be shocky. You know, if they got air in the chest, not blood in the chest, they may not show shock from hypovolemia, but they would show shock from what? Hypoxia, exactly. Tension pneumothorax, we're going to decompress that on the affected side. Now, according to our protocols and most protocols, we don't want to just randomly stick them and go, oh, I think they have a tension pneumothorax. Well, here, if he doesn't have one, we're going to give him one. Just slide that baby in. There are some criteria that you have to meet in order to decompress the chest. One would be they have severe respiratory distress and they're cyanotic. You recognize that by looking at them. Loss of radial pulse. What does that tell us? Loss of radial pulse. The blood pressure is low. That means you don't have to run in there and start taking a blood pressure. If you can't feel a radial pulse, then their blood pressure is going to be what? It's going to be certainly below 80. So I'm probably even going to check one here too, even if they're still alive. Femoral pulse is difficult to check. Decreasing level of consciousness. These people kind of start to circle right in front of your eyes. So you're going to need to be observing them the whole time. Cardiac tamponade. Tamponade, we're looking at 3 parts of Beck's triad. Y'all are familiar with that already. Hypotension, distended neck veins, and we don't really listen so much for heart sounds. If you want to do that, maybe y'all are. I don't know. I never did it. But those are 3 parts of Beck's triad. But you can see that as blood accumulates around the heart, what is the heart not able to do? It can't get a good compression there. It's not going to be able to eject much blood. It can't get much blood in, can't get much blood out. So since it can't get much blood in, where's that blood backing up, Mason? No, it's not. Yeah, it's going to back up in the venous system. What is paradoxical pulse? I typed this in here to give you. Yeah.
Radio.
Yeah. You lose usually about 10 to 15 millimeters of pressure when you take that breath, and that's because as the lungs expand, it puts even more pressure on your heart, so it's going to drop your heart rate temporarily. Cardiac tamponade, there's not a whole lot you can do for that. This is going to be a strictly load and go, monitor the airway, provide oxygen, and again, if the blood pressure is low, we're only going to titrate to the radial pulse. Once you get a radial pulse, then you've given enough fluids. Now, because of what's going on in the heart with all that, the sac filling with blood, you're going to be looking at a lot of dysrhythmias. And if you have certain dysrhythmias, you may need to treat those based on what it is. And then if they've got a cardiac tamponade, they may have other injuries in the chest. So you want to watch for pneumothorax, hemopneumothorax, and that sort. Myocardial contusion. What's a contusion? A bruise. So you're talking about a bruise to the heart. It usually comes about because of a blunt injury. The signs and symptoms are going to feel a lot like, or appear a lot like, they're having a heart attack. You know, chest pain, shortness of breath, dysrhythmias when you put them on the monitor. You're going to treat them the same way. Titrate the blood pressure, titrate the radial pulse, and manage any dysrhythmias that you have, and rapid transport. Traumatic aortic rupture. This is it's not an uncommon result of a high-speed crash. Not good. Most common cause of immediate death. We usually don't have to treat these people because they're dead right there. We see it if they have a fall from a height, a very high height, when they are ejected from a vehicle. We see it. Sometimes there's no obvious sign of chest trauma. You know, I told you that, you know, you've got those 3 impacts. That 3rd impact is when the heart slings on the aorta, and it may rip right there at the where the aorta connects to the heart. It's where we see it most commonly occur. If you are doing a lot of blood pressures on this patient, which you're probably not because they're probably dead, usually they're going to have a higher blood pressure in the upper extremities than the lower extremities. Not sure how you're going to detect that other than you're feeling for a pedal pulse and you don't feel one. Tracheal or bronchial tree injury, that's going to be in the lungs. If something has compromised that, that's going to compromise their breathing. In this case, this is one where you'll see subcutaneous emphysema, up around the top here where the bronchus or the bronchial tree has been compromised and air's gotten out. You're probably going to have to intubate these patients because the air is not going where it needs to get. And you may have to try to make sure you extend that tube, maybe possibly a little bit deeper than you normally would, but not to do a right stem intubation. And then, of course, watch them for hemopneumothorax. Diaphragmatic tear, if the diaphragm is compromised, that's going to compromise breathing, right? Probably one of the biggest problems you're going to have with a diaphragmatic tear is if you get a herniation of the abdominal organs as they move up in there. One of the ways that you'll notice that is when you look at the abdomen, there's going to be a depression right through here where some of the abdominal contents have moved upward. Of course, when you get that movement upward of that, then you're going to get some presentation almost like a pneumothorax, a tension pneumothorax, because it's going to be taking up space in there. The lungs can't expand very well. You may, when you're auscultating the lungs, you may actually hear some bowel sounds, which is kind of creepy. Oh, you got bowel sounds like right here. That's kind of weird. Breath sounds will be diminished because of the pressure that's going to put on the lungs. They're not able to fully inflate. Oh, I wrote that in here. Scaphoid. Do y'all know what that meant? Scaphoid. That's going to be like sucked in. If you look up the definition, I think of it more as a depression in there, where it sucks in. Pulmonary contusion. This is going to be bruised lungs, right? Usually the result of, blunt trauma. Now this takes a while before it really starts to compromise your patient, typically. But you will notice that they become more hypoxic as it wears on. As with any bruise, bruise, you get a trauma, but it takes a little while before it starts to present itself. Blast injuries, they're putting a little bit more emphasis on this with the, terrorist kind of issues. With a blast injury, it's really going to depend on the size of the explosion and the environment that it's in. If the explosion occurs, in your closet or in your bathroom or some enclosed environment, it's going to be much more devastating than if they explode something out on the football field, of course. You see a lot of penetrating trauma. Sometimes when it's a terrorist in nature, they may put, just like the Boston bombings, they put shrapnel in there, objects in there that when it explodes, it hits people. So you may have patients with shrapnel. Other blast injuries. I listed these on here. They weren't on the original slide, but you've got your primary, which is going to be your initial blast, which is where you're going to get a pressure wave. I want to see.
That was the most non-discreet note.
Really? Let's put a slide up here so we can all enjoy it.
Who doesn't like that?
Joe won't want you to stop. We'll pause this. All right, let's continue on. I'm not sure what it has to do with the deadly blast. Okay, primary is going to be your initial air blast. Secondary is going to be when you're struck by the shrapnel brought about because of that blast. The tertiary is going to be the wave form that continues. It kind of propels the body into trees or other things that are around there. Quaternary is your thermal or radiation burns, and the quinary is if they put chemicals or materials in there that would create a dirty bomb. So those are the 5 different things. Is that 5? 1, 2, 3, 4, 5. Yes. Okay, impaled objects. There's nothing here that's new to you. Absolutely sure. You got impaled object. You've got to project, if you can, where do you think was all struck? Like, look here. What all's been compromised? The lungs, the diaphragm primarily. So you're going to have a respiratory issue on several fronts, right? You can have a pneumothorax, a tension pneumothorax, a hemopneumothorax. You can have problems with the diaphragm, got a diaphragmatic tear almost here. The diaphragm is not going to be able to contract normally. So you're going to have a lot of things going on. So depending on, now, you can see where this went kind of, but really you can't tell how long the knife is. I mean, it could have been 15 inches long. And you can't tell if it's been moved earlier from the time when you find the patient. You know, it could have started out somewhere else. So you got to monitor for just about anything that could occur in the chest. And you know, don't pull that knife out. You want to stabilize it in place. When's the only time you remove an impaled object? Yeah, if it compromises your ability to monitor the airway or to control the airway. Traumatic asphyxia. These can be kind of cool. I think this is Dr. Campbell's picture. And yeah, I tried to load another one yesterday, and all it gave me was the address line. With a traumatic asphyxia, we call that the purple cape. You'll recognize it in your patient right away. They're purple pretty much from here up, from where that break has occurred, because it becomes so hypoxic so quick. But the main thing is that's going to force blood. It's like when you squeeze a toothpaste, you know, and it just all squirts out. Here you're squeezing, the chest has been compressed, and all that blood in the heart and the vena cava is being pressed upward and backward, and it's like a toothpaste, somebody going, and so all the blood vessels pop in the top part of the body. Sometimes it looks like their eyes are bugging out, the tongue may be very swollen. It's a real nasty, it looks like somebody's just stamped on their chest and squirted everything to the north. Looks pretty nasty.
So is all that bruising on
No.
the chest right there? Because it kind of looks like he got burnt.
Yeah, no, it's not a good picture. It's Dr. Campbell's picture. He wanted it in there, I guess. It's not a real good one. But he's purple from right here, and it's because of the blood being forced very rapidly back up into that space. So as a result of severe compression of the chest, just forces all the blood out of it and back up. So cyanosis. Yeah, if you Google that, there were some really good pictures of traumatic asphyxia. You'll come up with some good stuff. That gives all of you guys something to do now rather than fall asleep. You too, Mason. Simple pneumothorax. What's a simple pneumothorax?
It's a simple one.
Yeah, it's not causing any problems really. Maybe a little bit of difficulty breathing, but
Well, it can cause some serious problems, but all it really is a dropped lung. You're not going to have the tension part of that, but now your patient is just breathing off of one lung. If he was an older person that already had respiratory disease, he drops a lung, it's a really big deal. But you're just not going to look for all the other things that come with the tension that you're going to have to treat. It's going to be very painful. I mentioned that earlier. Pleuritic chest pain, shortness of breath. You're going to have probably absent or decreased breath sounds on that side. You know, when you have a pneumothorax, that doesn't mean that, you know, I got two lungs, all of a sudden this one's like flat as a pancake. It's going to, usually, it's going to start slow, and it may build or it may correct itself, but maybe not all lobes are going to go down at once. You may just lose a collapse of one lobe, and the body's able to maintain the inflation of the others, or it may slowly progress and drop the entire lung. But decreased breath sounds will be what you'll be looking for here, and difficulty breathing. And then watch that it doesn't become a tension pneumothorax, because it may. Sternal fracture, usually because of a significant blunt force to the chest. You may actually palpate, you can feel that fracture or that movement. It's going to be painful for the patient. In the event of a sternal fracture, you're probably going to have cardiac involvement, cardiac contusion, possibly even a cardiac tamponade. Simple rib fracture. What's the main problem with a simple rib fracture? Simple indicating it hasn't punctured a lung, you know, it's not damaged anything internally. What's the main problem?
You don't want to breathe.
Yeah, it hurts to breathe, so you don't breathe. So is it life-threatening? Not usually right away, but if you've got an elderly person with rib fractures, they're not breathing, they develop pneumonia, that's it. But you will continue to monitor them for hemothorax and tension pneumothorax. Okay, chest injuries are common, in case you didn't know that. They can be life-threatening, immediately life-threatening. So your job is going to be constant assessment. You will be constantly reassessing that patient. You have to be ready to intervene if you need to. You know, if you've got to do a needle decompression, what things are you going to recognize about your patient very rapidly to know that you've got to needle them quickly? What are you looking for? Severe respiratory distress, cyanosis,
Blood pressure
and a very low blood pressure. Those are the main things you'll be looking for as far as your patient is concerned. But if you're not going to see them, if you're not looking for them, if you don't palpate that pulse, you're not going to know they've got a severely low blood pressure. But that'll be a tip-off. They can't breathe, they're looking bad, and their blood pressure is really low. Airway and oxygenization is always a priority, and you have to constantly be reassessing your patient. Constantly reassessing. This thing turned off while y'all say something to students.